All right, everybody. So we're going to start our discussion on the respiratory, urinary, and the reproductive systems in this lecture. We'll be starting with the discussion of the respiratory system. And as everyone should know by this point, the function of the respiratory system is to bring oxygen into the body as well as to remove certain waste products like carbon dioxide out of the body. This does multiple different things, but also plays a major role in controlling acid-base balance. And the lungs also play a rather interesting role in the control of blood volume as well, since they create angiotensin converting enzyme, which we will talk about later. Some other accessory functions that we find very important that our respiratory system is directly involved with is the production of speech, and the ability to cough, which can help propel things out of not only the respiratory pathways, but also the shared pathways that the respiratory system has with the digestive system, since the oropharynx, or the mouth, is essentially a respiratory and digestive area as well. So conceptually, two big things to talk about is the division of the respiratory system. So we have conducting and respiration zones. The conducting zones do exactly what they say they do. They just serve to conduct air, whereas the actual respiration structures are going to be deep within the lung itself. So pretty much everything that you can visibly see on this diagram here is conducting. Most of the respiratory structures are actually pretty much at the close to microscopic level. And in fact, I believe respiration does not occur until the 16th or so division of the bronchi. Okay, so as we move here, a big thing to talk about is the divisions of the pharynx. So there is the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx, as it is named, is essentially the connection of the pharynx to the nasal cavity. The oropharynx is the connection of the pharynx to the mouth, and our laryngopharynx is the area that encompasses parts of the larynx as well as the pharynx, where they kind of overlap. Again, as I mentioned before, the oropharynx is a shared space. Well, the part of the oropharynx and the laryngopharynx together are shared spaces between the digestive and respiratory tracts. It's pretty much just a conducting tube, but the way that we can divide whether something goes into the esophagus or air enters into the pharynx and eventually the trachea is a structure called the epiglottis. It kind of acts as a lid for the pharynx. I'm going to kind of skim through a lot of this anatomical type stuff. It's pretty straightforward, and some of it goes into a little bit greater detail than what you will need to know. A couple things to point out is when we talk about the thyroid cartilage, it's aptly named because it does sit right behind the thyroid gland, and the laryngeal prominence is what you would commonly refer to as like the Adam's apple, and it is readily palpable on pretty much every person's throat. The isthmus of the thyroid will actually cross somewhere below the laryngeal prominence and between it and the cricoid cartilage. Okay, and that again is important in physical examination of the thyroid, but that is kind of beyond what we're talking about here. So as you get into the trachea, which begins after the cricotracheal ligament underneath the cricoid cartilage, we've really entered pure respiration or pure respiratory system at that point. Our vocal cord diagram is here. It's pretty much a set of a large number of muscles, I should say. I believe there's 34 different muscles that make up the larynx. But functionally, we have vocal cords, which kind of they get tensioned, and they control the vestibular folds, and it determines the way that our voice sounds as air gets pushed through the larynx. One interesting thing to think about is the tracheal cartilage rings are going to be C-shaped. Why would that be? Well, because the esophagus will literally sit on the back side. Okay, so it's a just adaptation related to the fact that the esophagus essentially hugs the back of the trachea. So the trachea doesn't necessarily, and on top of that, the vertebral bodies are going to be just behind the esophagus. So really, we don't need cartilage there if we already have something tougher than cartilage protecting that space. One important thing to talk about with the trachea is its histological structure. So on the lining of the lumen, we have pseudostratified columnar epithelia. These guys have cilia on them, and this is very important, and this is part of why it has to be this type. These cilia exist to kind of push along mucus. Within the trachea, we're going to have mucosal glands, a couple different types, as well as goblet cells. And these guys make mucus. Mucus kind of serves as a immune barrier tissue in a way. It catches stuff in it, right? It kind of acts as like if you've ever seen the sticky traps that they use for flies, it's kind of the same concept. It wants to catch debris. It catches, bacteria and all kinds of stuff, and it helps function as a immunological protection for the actual lung. Because again, when we get into more in-depth lung anatomy, you'll see why that's so important. This is conceptually very important, though, because we can see issues related to too much mucus production. And if there's too much mucus production, or the mucus is too thick, like in cystic fibrosis, the mucociliary escalator, as this kind of concept is called, doesn't function properly. And you actually will get mucus buildup in the lung itself, since it cannot be cleared out essentially by coughing. So as we get into the bottom of the trachea, it's not labeled here, but this space right here where it splits into the primary bronchi, this is called the carina. The carina splits. We have primary bronchi, and then after that becomes secondary bronchi, which every lobe of each lung will have a secondary bronchi, whereas each lung only has one primary bronchi each. Okay, so the right lung actually has 3 different lobes. There's a upper, middle, and lower, whereas the left lung only has a upper and lower lobe. So the right lung will actually have 3 secondary bronchi, and the left only has 2. And from that point, they keep dividing. Conceptually, everything after secondary is kind of just referred to as tertiary, until we get to what's called the bronchioles. And the bronchioles are pretty much anything that's about 1 millimeters or smaller, and those will also divide further, and we eventually end up with respiratory bronchioles. And respiratory bronchioles are the first time that respiration actually can occur. It's because there's going to be a structure called alveoli with them. And this is, this can begin as early as I said earlier, the 16th to 17th division of the bronchial tree. So as we keep moving along, our respiratory bronchioles really turn into alveolar sacs at the end. We have sacs of alveoli, and these alveolar sacs are incredibly thin, and this is where kind of all the magic happens. They're surrounded completely by capillaries to allow exchange of gases and other substances, because in fact we do actually exhale substances that are more than just carbon dioxide and gas. We do exhale stuff like urea and nitrogen, etc. These alveoli are very small. They're pretty elastic, and they're not that tough, though, okay? One key thing to talk about is that they do need this substance on them called surfactant, because surfactant will reduce the surface tension on the alveoli, and if the surface tension gets too high, the alveoli will actually collapse, and that renders it non-functional. There is actually a congenital condition called alpha-1 trypsin deficiency, and it's characterized by a child being born. They don't produce enough surfactant or any surfactant at all in some cases, and their lungs will actually collapse in on themselves. So when we're going to talk about the lungs themselves, it's important to recognize that there are tissue layers that cover them. This is called the pleura. The pleural cavity is what the lung actually sits in, and each lung, as we talked about all the way back in cardiovasculature, each lung, the space between it, is called the mediastinum. That's where the heart, a lot of lymphatic tissues, vasculature, etc. will sit. The visceral pleura is the pleura that actually lines the organs themselves, whereas the parietal pleura is what contacts the thoracic wall. The pleural cavity is the space between the visceral and parietal layers, and there is actually pleural fluid that is within that space. Very, very, very thin. Anywhere from, I've seen numbers as low as 15 milliliters being in that space. And the pleural fluid is created by cells that are commonly grouped together and called mesothelial cells. If you know anything or have heard a term similar to that, it would be mesothelioma. Mesothelioma is essentially related to those cells and is an oncological condition related primarily to exposure to inhaled particles that cause lung disease. Most commonly, you'll see asbestos, but like coal workers' lung, any form of pneumoconiosis, realistically, any inhaled lung disease can theoretically lead to it. So it's stuff like silicone, iron, coal, very common in people that have been construction workers for a long time, worked in shipyards or other types of factories. So now moving on, the process of breathing. Ventilation is a kind of two-step process. There's inspiration and expiration. Inspiration brings air into the lung, and the primary thing we look at with inspiration is our diaphragm. Our diaphragm is actually attached to our abdominal wall. It's attached to vertebrae, ribs, the sternum. It's all over the place. And when the diaphragm contracts, it actually lowers into the abdominal cavity, and it creates this extra bit of space for the lung to expand into. And this is important because the lung actually sits there's a minor pressure gradient differential between the lung and the outside environment. Very minor, but incredibly important for the ability of the lung to expand passively. So when the lung is given more space, when the diaphragm moves down, air will actually come from the external environment into the lung. This is actually very efficient, all things considered, because if we had the same pressure inside of the lung as we do in the atmosphere, we would actually need essentially more specialized musculature to cause the lung to expand. But because the lung is developed in such a way that it has a very minimal reduction in air pressure, the pressure will actually rush in from the external environment when it's given that space. So the diaphragm is our primary inhalation muscle, but our external intercostals play a role in that. And so can other muscles that we won't focus too much on, but if you think about where they attach, our scalene muscles and our sternocleidomastoid, they help expand the thoracic cavity. When we exhale, the diaphragm actually will relax, and if we really force it, our internal intercostals will actually really pull the chest down tighter. And it causes kind of a recoiling type effect, and that pushes air out of the lungs. Couple things to also talk about is spirometry. So some of the terms that you're going to see here are related to the testing that occurs when we do pulmonary function testing. Tidal volume is the amount of air during normal breathing. So when you're just sitting, watching TV, not focused on your breathing, that's the volume of air that goes in and out of your lungs normally. There is inspiratory reserve, which then is the amount of air, the amount of extra air that you can inhale beyond your normal tidal volume. So if you are normally breathing, you hit the end of your normal inhalation, and then you start to measure the amount of volume after that. The exact opposite exists is expiratory reserve volume. You've exhaled during tidal volume, and then you force out the rest of the air that you can. Residual volume is then kind of what's left after you've forced as much air out of your lungs as possible. There are two main things that kind of influence this, but the biggest of this is related to anatomical dead space, which is where air can get into the lungs and it doesn't actually ever participate in exchange because there's no functional alveoli to reach. Respiratory rate's another thing that's essentially, the number of breaths taken per minute, just like heart rate. Normal number for that, as we know, normal heart rate is listed in the range of 60 to 100. Realistically, the average is going to be, a true resting heart rate, somebody who's just sitting there, about 75. A normal respiratory rate for a full-grown adult is going to be between 12 and 20 breaths per minute. Breathing should realistically not be labored. You shouldn't be able to hear it when people are resting. So if somebody, you see them really forcing breaths out, you can hear like or constantly, that type of sound. They're breathing in a very labored manner. Sometimes you'll also see the neck musculature that I talked about earlier, the scalenes and sternocleidomastoid. If those are really getting involved in somebody who's at rest and breathing, they definitely have a issue. Most likely related to low too high of carbon dioxide. And that leads us to our next point about the importance of carbon dioxide. Our body does not actually measure the amount of oxygen. It actually measures the carbon dioxide. And it does this in a special area at the carotid arteries in the neck. Your carotid artery will split into the external and internal carotid. And at that split point, there is an enlargement called the carotid sinus. The carotid sinus is innervated by cranial nerve 9, the glossopharyngeal nerve. And it is chemoreceptors that help determine the number or the amount, concentration of carbon dioxide. If there is too much or too little carbon dioxide, it then has a feedback loop into the brain and can help stimulate heart rate via the effector, which would be the vagus nerve, cranial nerve 10 in this case, primarily by influencing the heart itself as well as the lungs. So moving on, the urinary system. Urinary system is kind of the middleman between these two guys. The respiratory system, believe it or not, it actually does, we don't really think about it this way, but the respiratory system exists to remove waste from the body, primarily gaseous wastes, but we do, as I mentioned already, we do exhale very small amounts of urea, which is the primary waste product that the kidneys will concentrate and makes up the vast majority of the waste product that is urine. Another huge thing, though, about the kidneys is it plays such a major role in the regulation of things related to blood. It secretes a substance called erythropoietin, or EPO. This stimulates red blood cell production. The kidneys also play a huge role in regulation of pH. They control the amount of resorption of electrolytes and water, etc. And they play this huge, huge role in our ability to respond to low blood volume. Okay, and this is really where another aspect that the respiratory system ties in, and that's the angiotensin converting enzyme, ACE, that I mentioned already. So, as you look here, the kidney is relatively straightforward function. We have blood vessels that come in. The blood vessels allow stuff to leak out. Blood enters into the nephron. It gets filtered and it starts to collect in the calyxes and pyramid. And then it all kind of filters into the what's called the renal pelvis, which is right here. And then it goes into the ureter down to the bladder for storage until it is to be removed from the body. The functional, as I mentioned it already, but the smallest functional unit of the kidney is the nephron. This is primarily where all the action happens, all the filtration. And the nephron is composed of a couple different things, but it's going to have the capillary bed, a glomerulus, and Bowman's capsule. So as you're looking here, we see the blood enter into the glomerulus via the capillaries. Stuff will then enter into this guy here that we'll talk about. This is the proximal convoluted tubule. It will then drain down the thick descending loop of Henle and then the thin descending loop until it gets to the ascending loop of Henle and then the distal convoluted tubule, and then it actually does drain at that point. Another important aspect that's not on that document is what's called juxtaglomerular cells. These guys help regulate the ability of the kidney to filter. So they can increase or decrease, and they play a major role in sensing blood pressure. They're actually the primary signalers to create the hormone renin, which we will talk about here shortly. As we move down the filtering apparatus through the distal convoluted tubule, we then end up in the pyramids, the calyxes, and then the ureter, eventually the bladder. And at that point, once it leaves the bladder, the urethra is where urine is carried during the process of urination. The urethra is different between males and females. Female urethras are much shorter, which leaves them much more at risk for things like urinary tract infections, as bacteria does not have to go very far before reaching something that's easily infectable, whereas the male urethra is much longer by comparison and will actually consist of slightly different parts. There's a prostatic component, there's a membranous component, there's the actual penile component, etc. But that's the only urinary piece of anatomy that actually differs between male and female. The bladder can, in an average normal person, hold between 500 and 600 milliliters of urine, but it's very possible for it to expand beyond that. The structure of the bladder is rather interesting. It's the only place in the body where we have transitional epithelia, and it is also a kind of a giant smooth muscle called the detrusor muscle, which realistically works very well for something like a bladder where you need a muscle to kind of squeeze out fluid. One big thing that is important for the micturition, which is the term for the act of voiding urine, is that you do need an intact spinal cord for this to occur. Just like the ability to voluntarily void your bowel. One of the things that is often talked about with spinal cord injuries is loss of bowel and bladder control, whether you are retaining or involuntarily excreting. Those are both major issues, especially if you have any other types of symptoms. One of the more traditional prototypical conditions that will be blamed on this is something called Cauda-Equina syndrome, which is associated with all kinds of different things, but essentially it's compression of the lumbar and sacral spinal cord, and it causes lower limb issues as well as bowel and bladder dysfunction. So you'll see here that I won't spend much time on it really at all, but normal characteristics and values in urine, they're listed here. Big thing to mention, specific gravity. That is something that is relatively non-specific but very important because it's kind of the value of it's the measure of all of the substances within urine. Normal water is 1.0. So if someone is fully hydrated, they should realistically never be 1.000. Because there will be other stuff within the urine. And if specific gravity is too high, and other stuff is present, like protein, glucose, blood, etc., that's also a major concern for the ability to detect how well the kidneys are functioning. So, on to tubular reabsorption. We're back now to our nephron. Remember the proximal convoluted tubule, the descending loop of Henle, the ascending loop of Henle, and the distal convoluted tubule. Each of these areas have a slightly different lined membrane, and they will all function in slightly different ways in regards to what they actually regulate. So certain areas are going to primarily resorb or excrete certain substances. So we have, again, a whole list here on what's being removed. A big thing to talk about is glucose. So in a normal, healthy individual, glucose should not be in the urine. Okay, glucosuria is something that is seen in severe diabetics because the body literally has like no space to keep the glucose, so it just gets pushed into the kidney, and that actually is the cause of diabetes-related kidney failure. Another important thing when we talk about kidney function is creatinine levels. Creatinine is a very quick, easy way to look at the filtration rate and filtration capacity of the kidney itself. Bicarbonate is another thing that's very important. It needs to continuously be recovered in order to be used as a acid-base balance controller in the blood. As you know, with the digestive tract, our pancreas secretes bicarbonate. Bicarbonate is our body's main acid-base controller, and it is a base to help keep us within our normal acid-base balance, which is actually very, very tightly controlled. If it's between about 7.35 to 7.4 pH, which is a very, very, very small range. But our body has to stay within that to maintain homeostasis and function properly. Okay, so renal blood flow, as we mentioned before, controlled by juxtaglomerular cells. They cause vasoconstriction and dilation at a very localized level to control the amount of blood flowing into the nephron. Now, something that's very important to talk about is the renin-angiotensin-aldosterone system. So renin, as we mentioned before, is made by the juxtaglomerular cells. If the body were to have a sudden massive drop in blood volume, let's say you are bleeding, right? Let's say you've got a deep enough cut that you've been bleeding for 2 hours now. You're waiting in the emergency room, etc. The body is going to activate this process in an effort to keep the homeostasis in the proper level of blood volume. So the juxtaglomerular cells will detect that blood volume has dropped below, or blood pressure has dropped below a certain point. And this is because if you're losing blood volume, you will actually lose blood pressure because there's less substance within the vasculature, which means there's less stuff pushing on the walls of the vasculature, which is blood pressure. So blood pressure drops. This causes the juxtaglomerular cells to release renin. Renin ends up reacting with a liver enzyme called angiotensinogen. And this gives us angiotensin 1. Angiotensin 1 will then interact with ACE, primarily produced by our lungs, to give us angiotensin 2. Angiotensin 2 is the main activator guy here. He's primarily going to focus on reuptaking water, but A step that's not listed here that is arguably just as important to further exaggerate our ability to retain water, angiotensin 2 will activate a hormone called aldosterone. Aldosterone is secreted by the adrenal cortex, and it's a corticosteroid hormone, and this will actually cause the kidney to retain more electrolytes. And as we've talked about before, water loves to follow electrolytes, so this further reinforces the ability of the kidney to retain water. So not only has the Lupa-Hindley been told, hey, we need to keep more water, the entire nephron has been told, hey, we need to keep more salt. And that means water will be able to follow the salt through the filtration membranes at all points of the nephron, which allows for greater resorption. It's very interesting and incredibly important process for maintaining our homeostasis. So, male and female reproductive systems. So this is kind of the last big system that we'll talk about, because in the next week we'll be focusing on genetics and hereditary stuff. Really, the whole purpose of the reproductive system is to create gametes and have a way for these gametes to be introduced together to create a offspring, right? So the male system primarily exists to bring the sperm as close to the egg as possible. The male system is also relatively simple in comparison to the females. Spermatogenesis is the term given for the creation of sperm, and this occurs in the seminiferous tubules of the testes. The testes are primarily made up of seminiferous tubules, but there are some other structures in there. There's a couple muscles. There's a cremaster muscle, which helps regulate the temperature of the testes by withdrawing or allowing them to extend. And then the scrotum is the muscular sac that holds the testes outside of the body cavity, which again is a important thing for controlling the temperature of the testes. If the testes were inside of the human body, the sperm would actually not develop as well and would generally not be very effective at all. They need 1 to 2 degrees lower temperature, which is why the scrotum is contained outside of the body. And this, the fact that this is contained outside of the body kind of creates a weak spot in the abdominal wall, and it allows things like hernias to occur, where you can get tissue that gets pushed down into the scrotum. Sometimes it's fat, sometimes it can be really bad, and it would be a piece of intestine, which can then, become strangulated, etc. Also, the sperm cell is the only human cell that has a flagella, which this is actually a very important thing when we talk about the immune system, because our immune system will actually trigger on flagella. There is no ability to not. Flagella is pretty much always characterized by a protein called flagellin, and that's another reason why it's going to be contained in this kind of isolated bit of anatomy outside of the body. So, testosterone is the primary male sex hormone that's responsible for stimulation of the Sertoli cells to create sperm. Luteinizing hormone will primarily stimulate something called the cells of Leydig. These are cells that sit in the interstitium, and they actually will produce more testosterone, whereas follicle-stimulating hormone in males will stimulate Sertoli cells as well, and the Sertoli cells are primarily involved in stimulating the production of sperm. So these kind of overlap, again, where we can have a further increased production, and it does use a negative feedback loop. Now, the female anatomy is designed to do two things. One, provide a safe, secure environment for the development of an offspring, and two, allow the male reproductive gamete and the reproductive system to get close enough to that protective environment that an offspring can be created. So the two main, the two main structure, or three main structures. Internally, we have the vagina, which is kind of the canalway in, and then there is the uterus and the ovaries. The ovaries are the female equivalent of testes, whereas the uterus doesn't really have quite the same equivalent in males, but that's because it serves a very different function than any part of the male reproductive system. So what you're going to see here, there was already a diagram of this before about spermatocytes, but the same concept applies with oocytes or eggs. We learned about mitosis already, but in order to create gamete cells, we have to undergo a process called meiosis, where there's actually a secondary division that occurs, and it results in only half of the normal chromosome, or half of the normal genetic material, so that when the two gametes join together, you end up with one full set of genetic material, which allows for the creation of an offspring. We would not be able to have viable offspring if the numbers did not match up. So if, for instance, two normal cells fused together that both had full count genetic material, you would end up with realistically a non-viable offspring. So these are the kind of steps that the oocyte takes within the ovary. Unlike males, females will develop pretty much all of their eggs early on in life, and they kind of hang out there and wait. There are more eggs produced than the number of eggs that will ever be secreted, I guess you could say. But the idea is that the eggs will mature. They kind of develop this special nucleus, and then they will actually get released out of the ovary, down the fallopian tube, and then eventually into or close to the uterus. And if they are fertilized, they will implant onto the uterine wall. So the hormone control of the female reproductive system is a lot more complicated. There are three different phases. There's a follicular, ovulation, and luteal phase. The follicular phase stimulates the oocyte follicles that we saw on the previous page. It stimulates one of those to begin growing in preparation for release. The primary effect of this is on the follicles itself, and it's going to cause the endometrium to thicken up. as well, which is kind of a preparatory step as well. The ovulatory phase, we see in LH a luteinizing hormone surge, which really then stimulates further development of the follicle and release of the follicle, as well as kind of the final preparations of the endometrium for taking and having a implanted fertilized oocyte. And then our last phase is the luteal phase. And essentially what happens here, the corpus luteum, if there's no implantation into the uterine wall, we actually see a process that causes an inhibition of the hypothalamus, which means less GnRH, which causes the anterior pituitary to produce less LH and FSH. And the overall, when the corpus luteum is kind of dying, when it exists there, it produces progesterone. But when it is fertilized, it won't. And that's when pregnancy kind of occurs, and these next steps don't happen. So once the corpus luteum's kind of done, you'll see a drop in LH and FSH, and you'll see the initiation of the degradation of the stratum functionalis of the endometrium. And the stratum functionalis is one of the layers of the endometrium. It's the one that's primarily responsible for the implantation of a fertilized oocyte. That happens because the sloughing off of the endometrium occurs when the body no longer requires to maintain that tissue. And as we've mentioned at various times throughout the course to this point, the body does not like to maintain tissue that it doesn't have to. And what you'll actually see in the endometrium, there's vasculature that embeds it, and it will actually undergo this rapid spasm, which actually literally causes that layer to fall off. And that's what produces what we commonly will see referred to as the period, the menses. Another accessory organ related to not so much reproduction, but the ability of the female to raise a child is the breast. They are also influenced by the same hormones, which is again why it's kind of grouped in here as an accessory sexual organ. But we kind of already know, the breast will be stimulated to produce milk, and that's also regulated by FSH and LH. So, birth control pills, they primarily, most effective generally types are hormonal. They take advantage of the negative feedback system and kind of force the body to maintain a steady position within the menstrual cycle. So the last final thing to discuss for this week is kind of the development of the male-female reproductive differentiation of the embryo. The female biologic sex is considered kind of the default, and there are chemical signalings that occur to cause a shift to male. There's a special region of the Y chromosome, which again is only available on males. It's the sex-determining region, the SRY. Females don't have one, so essentially that gene exists to regulate this process. And part of that process would actually be essentially the creation of the Y chromosome. Other than that, though, a lot of processes are very similar. Early on, the eggs will start to develop pretty soon. And development kind of follows from there. Now, in males, the ability to continue differentiation into normal biological male requires the creation of Leydig cells, which again is a function of the SRY gene. Once the Leydig cells are created, more testosterone is going to be available for further stimulation of those male developmental processes. As I mentioned before, there are kind of embryologic equivalents between male and female reproductive systems, even though they look different. You see some examples listed here, but the idea remains the same, that the tissues kind of do a very similar job regardless of whether they're in a male or female. And this is pretty important that we develop them in a similar way, just because of the fact that there is a sort of default sex. Beyond as an embryo, further development and differentiation will occur with puberty. This is where really testosterone and estrogen themselves play a major role in development, which is why you see boys undergoing puberty. They have a lot more androgens, which causes further development of muscle mass, height, bone density, etc. Whereas females will begin to develop the quote-unquote characteristic female patterns, like the development of breast tissue, the they'll undergo menarche and will collect fat in certain parts of the body that are characteristic with the female sex. Puberty typically it has been decreasing in onset of age. Seems to be around 13 or so now, but there are also some factors. There's a lot of factors that we don't quite understand about this anymore. Another thing to consider, it's kind of alluded to here, but it's not just in females, but in men too. If you are in an energy deficient state, you are at risk for not entering puberty. You're also at risk for not having healthy reproductive systems. And one of the things that was commonly previously attributed to females was something they used to refer to as the female athlete triad, that they now have actually changed the name to. They call it relative energy deficiency in sport. And the idea behind it is that essentially people are more susceptible to injury because they're in this negative energy balance. Females will have low body weight, low fat mass. They will have amenorrhea. And as a result of kind of all of these factors, they actually can be a very young person with osteoporosis, which leads them to more risk of further injury, etc. It can happen in men, but it's a lot rarer.